Thank you very much for your kind invitation. Let me change the topic. I do mostly vitreoretinal surgery, mostly a medical retina. Then I'm going to show you three topics, three small cases. Very short cases. Two about myopia and one about illuvion. In the cases we use illuvion in some cases with severe hypotony, trauma, PVR, or something like this. Let me share with you the very first case. The very first case is a macro hole with disguises. You can see here is a 49 years old female with high myopia. Right eye is 30 millimeters of axial length. Left eye is 32.2 millimeters, and there is a posterior staphyloma mostly in the left eye of 2.4 millimeters in height, measured by B echography. And the patient came to me, sent by another surgeon, just to think about macro buckling in a case with 6 months progressive visual loss and metamorphopsia. You can see visual acuity was 20/125, and as you can see here, you have a posterior staphyloma, some RPE, disturbance in the posterior pole, and here you can see a full thickness macro hole with ascites, the posterior hyaloid, the schisis of posterior hyaloid. Then this was 3.5 years ago, and I was doing a macro buckling for these cases, to change to do only embedded flap for these cases. Then, was my first case. I convinced the patient to change, because many surgeons say that, you don't need macro buckling for these cases. And they say, okay, let's try it. Let's make a series of cases doing this surgery without macro buckling. Then, I convinced the patient, and I did my surgery. This is a phakic patient, as you can see. We did, 23 gauge vitrectomy, and you can see we removed the vitreous there with the 23 gauge. I use only one light. You can see here something that may resemble, the Weiss ring, and then we remove the vitreous, and it's very easy. Then I stain. I never use triamcinolone. I have to tell you, many surgeons in the world, they use triamcinolone. I always use brilliant blue, yes, from the very beginning. And then you can see here how the posterior hyaloid is attached in the inferior arcade. I think to speak about posterior vitreous detachment in these kind of cases, this is a mistake. You can see the macro hole there, and then the posterior hyaloid, in the majority of these cases, they stay attached to the retina. Even if you see a ring just floating in front of the optic disc that says Weiss ring, don't believe that the hyaloid is detached. Because the posterior hyaloid staining is very typical. Is irregular staining. The posterior hyaloid is very elastic. It's difficult to control where you go. You just pull, and the posterior hyaloid comes to you. And here there are three questions for me, because there are many surgeons that say when there is these kind of cases, they try to remove the posterior hyaloid to the extreme periphery in the cases of myopic maculopathy. And I tell you, my opinion about this is not to do it. I try to preserve, the peripheral retina for any break. I don't try to go to periphery, because in these kind of cases, in some of them, they have very strong attachments of the posterior hyaloid, then you can promote breaks. And you convert a myopic maculopathy to a retinal detachment in a high myopia. This is a terrible thing. And what would be the next step? The next step for me is to re-stain, to see perfect, the internal limiting membrane. And this is, I always use only brilliant blue. You see here perfect the internal limiting membrane. And we start in the inferior part of the retina, as you can see here with the forceps. And then we make a rhexis around the macro hole. I try to decrease the pinching numbers, you not try to pinch and pinch. I try to, make the less pinch as possible. And then we put all these ILM around the macro hole. We are creating now the superior to inferior flap, just to cover, the macro hole. My advice is don't press down. You don't need it. Don't try to put the ILM inside the hole, because you can promote, RP lesions. Don't press down. You leave it there. And then my question to you is, could anyone have done something else? Because there are some surgeons that say that in these holes, the viscous fluid inside the hole perhaps prevents macro hole closing. And I did. I went with my 41 gauge camera before to peel the ILM. I went to just inside the macro hole. You have to be very stable, just to exchange this vitreous, this viscous liquid fluid inside the hole. And then after this, I started to peel the ILM I showed you before. Okay, after this, we trim the ILM. As you can see here, how to trim the ILM. Lower your cutting rate and lower your suction. This is the most important thing. And then when you aspirate in the inferior part of the retina, because all the fluid coming down from the peripheral retina, peripheral vitreous, up and down, make a current and maintains the flap, the superior flap over the hole. Some surgeons, they make, the temporal flap, but, at the end, my patients, if they are, walking, then, I prefer the flap to be from superior part to inferior part to be maintained there and to close the hole. And then I'm sure you're expecting a perfect closed macro hole. And, this is the perfect inverted flap, but, the macro hole remain open. This is 4 weeks after surgery. The patient was very angry with me because I convinced her to avoid, macro buckling and only do this, because many surgeons told me that, in many meetings, they say that you don't need it. At the end, visual acuity was 20/200. And what's the next step? Well, the next step for me, first, why did it fail? You have any explanation about this? And the next step, of course, I did macro buckling in this case. And then, macro buckling, just to remind you, this is, you open the supratemporal quadrant, then you put a matrix suture pointing the macro area where you think there is the macro area. It's not that easy because it's, huge variation. And then I went there just to see how was my inverted flap. And my inverted flap was there, was perfect, was over the hole. And then I began to touch my flap, and at the end I lost the flap. The flap was a free flap, and then to put the flap again inside the hole is so difficult. Let me ask you, what is this? Let me ask you, what is this bubble? I expect your answers. Then with two flexible loop, I went there. This is not that easy. Then the trick is to put again under perfluorocarbon liquid the flap, and then very, very softly you drag this ILM flap to put the flap into the hole. Look at the bubble I showed you before. This gas bubble over the perfluorocarbon liquid. Then we put this macro buckle. I think is the best buckle. The buckles I tried. There's a light in the platform. You can see the blue dot there. But at the end, when I remove the perfluorocarbon liquid to final exchange, then the blue dot disappears. And then I didn't have any flap over the macro hole. Then I make a fluid exchange SF6 20%, and the macro hole was closed. Visual acuity was not fine. This is 3 years. And this is not the aspect of 3 years. I don't have here's the aspect of the scases have disappeared, but visual acuity remains in 20/100. This is not a good result. But let me confess that was my first case doing the inverted flap in cases with macro hole and scases. I did it with macro hole without scases a lot of time ago. And the series continues. And as you can see here, we were able to close. This is the first case I showed you before. And as the series continues, these are 8 cases here that we were able to close the macro hole. Well, to say to close a macro hole is, look at the last case. This is 6 months ago, and this is a perfect visual acuity is 20/63. This is a very good 20. Excuse me, it's not 20. 2032, and visual acuity was very nice, 2032, as I told you. But the macro hole remains open. The patient, has decreased metamorphopsia and it's perfect. And we are expecting this to close spontaneously. The second case is a nightmare. Let me ask you about if you have seen any case like this. This case is a macro hole without skies in a high myop. This is a 53 years old female, high myopia, radial keratopathy when she was 18 years old, and 1 year ago she was operated cataract surgery and IOL implantation. She showed 15 days moderate visual loss and metamorphopsia in the right eye, and visual acuity was 20/50. Okay, we went to the surgery, and this is the surgery. It's very similar to the case I showed before, and we perform our vitrectomy. We stain with brilliant blue. As I repeat, I don't use Jamsinolone to stain is not a good word for this, but to stain the posterior hyaloid. We start with the posterior hyaloid. This is a new forceps. I was testing this new forceps. I didn't like it too much, but I began with this, removing first the posterior hyaloid again. And after this, we re-stain to find the internal limiting membrane. At the end, we remove the internal limiting membrane. We create the inverted flap, superior flap to the inferior retina. As you can see here, don't press down, don't put the flap inside the hole, just a little bit, to the inferior side. Then you aspirate in the inferior part of the retina, as you can see here. And the day after the aspect is this, and this is a very good aspect. I do OCT the day after in all of my cases. And as you can see here, you can see the ILM there with the reflex of the gas in here. But the aspect was good. 3 weeks after the surgery, the gas had disappeared. The patient came to me and told me visual acuity was very poor. It was around 2200, and she was telling me, I have central scotoma. I cannot see your face. I cannot read with this eye. And look at this, the OCT, the macro hole was closed, but this bumpy areas over the RPE. Perhaps you're thinking about subretinal membrane, but this is not typical subretinal membrane. You can see many bumpy areas here over the RPE. And the patient said, my vision is very poor and my vision is worse than before. And perhaps you are asking me to show you an OCTA. The OCTA said nothing. There were no choroidal neovascularization in this case. Let me show you the autofluorescence in this case. This was not before. This is a terrible RPE lesion, both in the posterior retina and the anterior retina. Of course, you are thinking about why did it happen? And perhaps you're thinking toxic phenomenon. But this is brilliant blue. This is the same brilliant blue I always use. There are many papers saying that brilliant blue is not toxic. And the surgery was normal. It takes 30 minutes around to do all the surgery. Perhaps you think about phototoxicity, but remember here is the place where there is the entrance of the light. And you point down to the peripheral retina. Then I think it's not possible to have phototoxicity. I always show this case in the meetings when I speak about macro holes in high myopia, because I'm trying to know why this patient developed this, because the other eye is high myop. Then the other eye may show the same problem in the future. Only one surgeon in the world, my friend from India, from Delhi, that I'm sure of, showed me a case that, it's not the same, but he had the same problem in a patient that he used brilliant blue from the same trademark. And look at this, he showed this bumpy, aspect over the RPE. But, the aspect of these RPE lesions are not the same. They respect the vessels, as you can see here. And, I don't think it's the same, but, if you have any case, please show me the case, because I'm trying to know why it happened to my patient. Look at this. This is a comparison of the two cases. I think the distribution of the RP is really different, and I don't think it's any relationship, but if you have any case, yes, show me. In the third case, and the last thing I want to share with you is this. you know, as a surgeon, we use these devices to control, you know, edema or trying to increase the pressure. But in some cases with silicone oil happen this. This is a case of, there was a PBR, this is the aspect after the surgery, after retinotomy, I injected Osirex in the cavity, and you know, the Osirex went over the retina. You don't want the Osirex to be there. Or in some cases with a very bad diaphragm, you can have these devices in the anterior chamber. And you know, in the anterior chamber, you can have the problem of, you know, corneal edema, descompensation, etc. My advice, if you have to use Osirex or Iluvien, because, you know, in some cases we use Iluvien, in very bad cases, you know, off-label, of course. We described in 2014, we describe how to, in these kind of difficult cases, to suture the Osirex to describe. Very recently, this is in 2020, has been described the same technique. We 1 year ago we had a case. We have done this 3 times with Iluvien. Let me show you the first case was 1 year ago, in a case of coming from PBR, was aphakic, was silicone oil, you know, a hypotenuse eye. We tried to recover and to increase the pressure in the eye. Then, you know, and then we did this. This is very simple to do. This is a 23 gauge knife, and then we remove the Iluvien from the injector, and then we use this suture to make a knot, and we put inside this. You have to be very careful because you can break it, right? Then we put it inside, and then we put it totally inside, and then we put the conjunctiva over this. And that's everything. That's all that I want to share with you. And I'm trying to leave.
Thank you very much, Dr. Carlos. On time. If there is any question from dear colleagues here, Dr. Saad, Dr. Carlos Patrizio, or Ahmed, to Dr. Carlos, or any comments?
I just have one question, Carlos. Just about your last case,
sure,
that you're showing the suture, the Iluvien.
Sure.
Do you push it all the way into the eye, so it's going to be fixated only at scleral level? How do you do that?
I put it just to the sclera. You know, in the sclera, I put the suture over the sclera, but it remains in the, you know, it remains attached in the tunnel of the sclera. Then perhaps you think, okay, you have less dosage inside the eye, but I do it like this.
Well, the reason why I'm asking you that, Carlos, is a very specific reason for that. The implant only releases the drug from one end.
Yeah.
So you have to be sure that you're putting the
open
end first.
Yeah. Yeah. We put
one, to release the drug. Second, that you don't want to damage it. So that's an important thing for the others to consider. You have to put it in the right position, otherwise it doesn't work.
You're absolutely right. And then sometimes we put the implant through the cannulas, not suture. We put inside the trocars, and then we remove the cannulas, and then we leave it in the sclera. But as you mentioned, it's very important to put it, you know, with the end, the correct end. Not in.
Is there any sign for the anterior or posterior side of the Iluvien? So you can judge this is the area.
We remove it. We remove it from the syringe. Then we grasp it, and then we put it in the correct position as it enters in the.
I mean, if it is moved in your hand, there will be no way to see which one is the side of releasing.
No.
But you have an experience.
Yeah. Remember, the bit of the Iluvien that will release the drug is the trailing end from the injector. So the bit that is going first is the dead end.
The end,
right? So if you're going to remove from the cartridge to use that way, you have to turn it around. You have to reverse the order, because otherwise you get the wrong end. So normally when you inject, the bit that goes first is the dead end. The release end is the trailing end.
Exactly.
So when you remove it from the cartridge, you have to turn it.
No, I mean, if in case it's there in your hand, there is any sign to know which is no.
I'll tell you, I haven't tried to do that, so I don't know visually if I would be able
to. Any other
comment?
comments? Okay, is there any
Yeah,
question?
I need just to ask. Thank you, Carlos. It's very interesting cases. I'm excited to know the result of the last case. What happened after you put the Leuven in such a interesting
Well,
way?
in this when we will use Iluvien in these kind of cases, these are cases that we are trying to increase intraocular pressure.
Yeah.
And to decrease the retinal edema. I have to tell you, I have done 3 times, and only one case increased 5 millimeters of mercury in intraocular pressure. I think intraocular pressure is for me, is my worst problem in severe cases, PVR, and in these cases that you have 1, 2, 3 millimeters of mercury.
What suture?
One more point. Oh, sorry. Go ahead, Doctor.
No, go ahead. It's fine.
Yeah, I'm just asking about the, we all know that the macular hole and posterior staphyloma with myopic, it's a challenging case, and you presented it very nicely. And I know that one of the tricks that you have to peel the ILM until the edge of the staphyloma to avoid that. Yeah. And one of the most challenging, one of the most common reason that, because for sure you position in the patient post-operatively, right? Because you need to have a gas bubble to fill all the staphyloma space. Do you think that suturing the sclerotomy, it will make sure that you are going home, you are feeling that there is no, because if you have any leak on the first post-operative days, the pressure of the gas inside the eye, it might soft, and then you might, especially are using 23 gauge, or you don't have this kind of point in your mind while you're dealing with it.
Very good question. Look at this. In the staphyloma, when you are doing these cases, you have 2 objectives. This is different to idiopathic macular holes. Idiopathic macular holes, you want to release the traction around the hole. This is no problem. Okay, in this case, it's different. You are trying to increase the retinal elasticity. Remember that the ILM is the most tough of the retina, more rigid part of the retina, among the vessels, the arcades. But in this case, I go around to the border, to the edge of the staphyloma, trying to increase as much as possible, the retinal elasticity. This is first answer. The second is the gas I use is SF6 20%. SF6 20%, in my experience, is a little bit expansive. But at the end, I do something special in the sclerotomies, and if I feel that the eye remains stable, I don't suture, but in many cases I suture to be sure that the eye the day after will have more than 3/4 part of the vitreous cavity full of gas, because some surgeons in idiopathic macular cases say, okay, I only use air. Okay, air is perfect, but you have to have, the eye full of air.
Sure.
Okay, thank you, Ahmed, because we are having, we are running behind the time, and we have many of our dear friends. They are attendees, and they are a well-known international speaker, and they want to ask a question. I will give 2 for this time. I have Dr. Nicola Ghazi. Dr. Nicola, we are happy that you are with us. Can you open the mic for Dr. Nicola to give his question?
Yeah, thank you. Thank you very much. Very interesting presentations. Can you hear me?
Yeah, we are hearing you, Dr. Nicola. Yes, go ahead.
Yeah, thank you very much. I appreciate it. Hello to all the dear friends and colleagues. I hope you are all safe and fine. I just wanted to comment on the, thank you. I just wanted to comment on the Iluvien suturing to the sclera. I've seen a different technique than the one that Carlos described, and I kind of like it because you don't have to worry about which end is inside the eye. This technique actually sutures the Iluvien circumferentially in the pars plana. So after the Iluvien goes all the way in, actually the Iluvien implant is sutured outside the eye, a slip knot is put around it, then the implant is thrown inside the eye, and then it's sutured just like we suture a haptic to the edges of the scleral wound, and it lies flat on the pars plana internally. There's no part of it that stays outside. And I was wondering if Carlos has an experience with this or any of the speakers.
No, but this is a good idea. I think it's a perfect idea, and you know, this avoids the problem that Carlos mentioned, to have too much. And in many cases, you don't see at the end. You suture the sclera over the implant, you don't see anything. But you know, this is a concern that I agree with Carlos that may be a problem. But you know, suturing for these kind of cases, and we are talking about severe retinal, vitreoretinal problems. This is not about uveitis. This is a big problem for severe cases. I think it may help some of them, traumatic cases, for example, trying to increase the intraocular pressure. Although, the main reason of hypotony perhaps is not inflammation. But in some cases may help to increase the pressure.
Thank you, Dr. Carlos. Dr. Nicola, thank you very much for your
thank you very much. Thank you, Dr. Amri.
Anyway, Dr. Nicola is all the times he's having a good, all innovations for something regarding vitreoretinal, well-known figures in the Middle East and vitreoretinal. Thanks for sharing with us your experience. I will have now Dr. Saad Wahib his question, then I will have also another question from one of attendees. Dr. Saad, if you want to comment or to do.
No, it was just great cases from both Ahmed and Carlos. I was just wondering what type of suture you would use when you're suturing these implants.
It's Prolene.
Prolene, okay.
Prolene, yeah.
Okay, so can we have Dr. Safwan Bayati for a question from live, please, Dr. Safwan.
Hi, Dr. Mohammed.
Hello, Dr. Safwan. Most welcome, dear friends. Please.
I just need to thank Dr. Mohammed first and all speakers for a very nice presentation, especially Dr. Ahmed and all of them, really all of them. I enjoyed all the presentation, but I need to thank Dr. Carlos for a very important point that he highlighted related to the Tripani Blue. Now, a few points, because I do agree with you, Dr. Carlos, that in few cases that when we are using the Tripani Blue once and twice and 3 times in the same case to highlight especially a very thin, delicate, especially in high myope with the posterior staphylomas. So I had also the same cases that one of them presented to me with the same RPE changes. And definitely at that time, when you ask yourself what's happened, I asked myself the same issues, but it's very clear. There's 2 issues, the Tripani Blue and phototoxicity. I don't think so that phototoxicity can ever create such a changes in Tripani Blue, in RPE. So mostly it's a Tripani Blue. I don't know whether you have any solution in your mind, any options to change, return back to the ICG or any other material that will be safer than Tripani Blue?
Let me tell you, I don't use Tripani Blue. I abandoned Tripani Blue. This is Brilliant Blue. This is not Tripani Blue. I never use Tripani Blue.
That's what I'm saying, you are taking it from which company?
It was Zork. It was Zork. Yeah, it was Zork. And the case from India was Zork. But I'm not sure that this. The thing I think is perhaps a personal, a relation with the dye. The characteristics of the patients of the RPE. But I haven't seen with Brilliant Blue. If you look at the literature, you won't find any paper that says that to the RPE toxic.
Okay.
Right.